Hello, today's topic is acute calculous cholecystitis. I am Dr. Parvez Ahmed Rishi. You can see in the diagram, we can see the cystic duct and the hepatic duct, they combine to form the common bile duct, and then the pancreatic duct joins. And here we can see in this diagram, there is a calculus, it is blocking common bile duct. Now, when this duct empties into the duodenum here, it is blocked by another calculi. It is an example, gallstone blocking common bile duct and pancreatic duct. It is blocking both pancreatic duct and common bile duct. Clinical problem: biliary colic develops in 1 to 4 annually, and acute cholecystitis develops in about 20% of these symptomatic patients if they are left untreated. Acute cholecystitis may coexist with choledocholitis, cholangitis, or gallstone pancreatitis. Pathogenesis: obstruction of cystic duct in the presence of bile supersaturated with cholesterol. Brief impaction may cause pain only, but if impaction is prolonged over many hours, and inflammation can result. With inflammation, the gallbladder becomes enlarged, tense, and reddened, and thickened, and an exudate of pericholecystic fluid may develop. Enterobacteriaceae family with Enterococci or anaerobes in majority of the patients is a cause. The wall of gallbladder may undergo necrosis and gangrene. Gangrenous cholecystitis. Bacterial superinfection with gas-forming organisms may lead to gas in the wall or lumen of the gallbladder. Emphysematous cholecystitis. Diagnosis: the main symptom of uncomplicated cholelithiasis is biliary colic caused by the obstruction of gallbladder neck by a stone. The pain is characteristically episodic, severe, and located in the epigastrium or right upper quadrant. It frequently follows food intake or comes at night. Patients commonly have pain with radiation into the back, accompanied by nausea and vomiting. Diagnosis is done by Murphy's sign, the arrest of inspiration while palpating the gallbladder during a deep breath, fever, elevation in the WBC and CRP LFT, systemic sepsis and organ failure, gangrenous or emphysematous cholecystitis, elevated serum amylase level, concomitant gallstone pancreatitis, gangrenous cholecystitis. In elderly patients, delayed in the diagnosis, common. The only symptom may be a mental status or decreased blood. Physical examination and laboratory tests may be normal. Profound jaundice, Mirizi syndrome due to cholangitis. We may go for ultrasonography to detect cholelithiasis in about 98% of patients. Acute calculous cholecystitis is diagnosed radiologically by the concomitant presence of thickening of gallbladder wall greater than 5 mm pericholecystic fluid or direct tenderness. With the probe is pushed again When the probe is pushed against the gallbladder, ultrasonography. This is called the Murphy's sign. Ultrasonographic imaging of the gallbladder. Here you can see a normal sonolucent gallbladder panel A, characterized by a thin wall and an absence of acoustic shadow. This is a thin wall and there is no shadow here. In a patient with symptomatic gallstone, panel B, the gallbladder contains small echogenic objects and posterior acoustic shadows. Here you can see the shadows. These are the stones, these are the shadows of the stones. In a patient with acute calculous cholecystitis, this is C, thickening is visible in the gallbladder wall along with a large gallstone. This is the gallstone. This is the shadow of the gallstone. Hepatobiliary scintigraphy involves intravenous injection of technetium labeled analogues of aminodiacetic acid, which are excreted into bile. The absence of gallbladder filling within 60 minutes after the administration of tracer indicates obstruction of the cystic duct and has a sensitivity of 80 to 90% of acute cholecystitis. The rim sign is a blush of increased pericholecystic radioactivity, which is present in about 30% of the patients with acute cholecystitis and in about 60% with acute gangrenous cholecystitis. Look at the diagrams. Hepatobiliary scintigraphy. In panel A, a normal liver is visible 10 minutes after the intravenous injection of a technetium labeled analog of aminodiacetic acid. In panel B, 55 minutes after tracer injection filling of the bile duct arrow and this is the filling of bile duct and gallbladder arrowhead are seen. In panel C, 1 hour after tracer injection in the patient of acute cholecystitis and obstruction of cystic duct is filling of the bile duct arrow but no filling of the gallbladder. There is no filling of gallbladder like here, but cystic duct has been filled. Diagnostic criteria of acute cholecystitis according to Tokyo guidelines. Clinical manifestation, local symptoms and signs, Murphy sign, pain, tenderness, right upper quadrant, mass or in the right upper quadrant, systemic signs, fever, leukocytosis, elevated C-reactive protein, imaging findings, a confirmatory finding on ultrasonography or hepatobiliary scintigraphy. Diagnosis is the presence of one local sign or symptom and one systemic sign and symptom is mandatory finding on an imaging test. Severity grading of acute cholecystitis according to Tokyo guidelines. Grade is mild, moderate and severe. Grade 1, 2 and 3. 1 is acute cholecystitis that does not meet the criteria for a more severe grade with gallbladder inflammation, no organ dysfunction. Moderate is the presence of one or more of the following: elevated white cell count, 18,000 cells per cubic millimeter, palpable tender mass in the right upper quadrant, duration is greater than 72 hours. Marked local inflammation include biliary peritonitis, cholecystic abscess, hepatic abscess, gangrenous cholecystitis, emphysematous cholecystitis. Severe grade, the presence of one or more of the following: cardiovascular dysfunction, hypotension requiring treatment with dopamine at 5 microgram per kilogram of body weight per minute, level of consciousness, or the dose of dopamine, neurologic dysfunction, respiratory dysfunction, ratio of partial pressure of arterial oxygen to the fraction of inspired oxygen less than 300, renal dysfunction, oliguria, creatinine greater than 2, hepatic dysfunction, prothrombin time, international normalized rate इतना, hematological dysfunction. So in the severity, it becomes more severe with more comorbidity. Treatment is timing of cholecystectomy, antibiotic therapy, and percutaneous cholecystectomy. Timing of cholecystectomy, so it may be early and late. Cholecystectomy can be performed by laparotomy or by laparoscopy, either at the time of initial attack, early treatment, or 2 to 3 months after initial attack has subsided, delayed treatment. Early has been variably defined as anywhere from 24 hours, 7 days after either the onset of symptom or the time of diagnosis. If delayed or conservative treatment is selected, the patients are treated during the acute phase and with antibiotics and intravenous fluids and NPO. Early laparoscopic cholecystectomy is the treatment of choice for most patients. The rate of conversion to open cholecystectomy is higher when a para, when laparoscopic cholecystectomy is performed for acute cholecystitis than for uncomplicated cholelithiasis. Predictor of the need for conversion includes WBC greater than 80,000, duration of symptoms of more than range from 1 day to 96 hours, age over 60 hours. The guidelines of Infectious Disease Society of American recommended that antimicrobial therapy be instituted if infection is suspected on the basis of laboratory and clinical finding. 12,500 millimeter cube or temperature 38.5 and radiographic finding, example air in the gallbladder or gallbladder wall. Antibiotic coverage against microorganisms in the Enterobacteriaceae family, example second generation cephalosporins, or a combination of quinolones and metronidazole activity against enterococci is not required. Antibiotics are also recommended for routine use in patients who are elderly or have diabetes or immunodeficiency, and for prophylaxis in patients undergoing cholecystectomy to reduce septic compression even when complications, even when infection is not suspected. Percutaneous cholecystectomy. Percutaneous cholecystectomy is often used when the patient presents with sepsis, severe acute cholecystitis according to the Tokyo guidelines, and in case of in which conservative treatment alone fails, especially in patients who are poor candidates for surgery. Guidelines: mild acute cholecystitis, early laparoscopic cholecystectomy is recommended. Moderate acute cholecystitis, either early or delayed cholecystectomy may be selected, but that early laparoscopic cholecystectomy should be performed only by a higher experienced surgeon and promptly terminated by conversion to open cholecystectomy if operative conditions make anatomical identification difficult. Severe acute cholecystitis, initial conservative management